Good morning. My name is Wilgus. I'm a pulmonologist at UCLA, and I'm here to talk to you today about chronic obstructive pulmonary disease, and specifically the impact that COPD has in women, which is a large-scale problem that frequently does not get the attention that it deserves. Feel free to submit any questions that may come up during the talk through Twitter with hashtag UCLAMDChat or on Facebook. And I'll address the questions at the end. These are the questions that I'd like to address during this talk. What is COPD? What is the history of how women took up smoking in the United States? Why does female sex matter, both biologically and sociologically? And how can we improve the treatment of COPD in women? So before we start talking about COPD, let's just briefly review the normal airway anatomy. The airways in the nose and the mouth converge in the trachea, which then splits into the right and the left main stem bronchi. And each bronchus branches out further and further into smaller airways. And at the end of the smallest airways are the air sacs or alveoli, where gas exchange occurs, where oxygen is taken up and carbon dioxide is released. So inhaled irritants like cigarette smoke can affect the lung in a number of different ways. The smoke can cause damage to the alveolar walls, which is called emphysema. When that happens, the lung becomes less elastic. It can become boggy with excess air trapping. And there's obstruction to airflow. The other way that cigarette smoke can affect the lung is by narrowing the air passages. So the muscle around the airway can become thickened. The lining of the airway is thickened, and the airway can become full of mucus, which also obstructs airflow. So the combination of emphysema and chronic bronchitis, which is that obstruction to airflow within the airways, both lead to airflow obstruction or difficulty getting air out of the lungs. And it's that physiology that leads to much of the sensation of shortness of breath from COPD. It really is a spectrum, however. So majority of patients will have a component of emphysema as well as chronic bronchitis. But there are some patients who will have only emphysema or only chronic bronchitis. And the symptoms of COPD include chronic cough, excess phlegm, breathlessness, especially with activity, so like climbing a flight of stairs or an incline or walking a distance, wheezing, fatigue, frequent respiratory infections, and exacerbations, which is when the symptoms may flare up in the setting of having a respiratory infection or being exposed to some sort of irritant. And it's important to note that these symptoms can occur decades after smoking cessation. So there may be some damage to the lungs that occurs with smoking that is silent for many decades, but only becomes apparent with symptoms when there's also a slight age-related decline in lung function. A threshold is met and symptoms develop. COPD is diagnosed with a breathing test called spirometry, which measures airflow in the lung. In normal lungs, which is shown here in blue, the majority of the air that is exhaled can be exhaled within the first second of that breath. When the airways are obstructed, it takes longer for the air to get out during an exhalation. And by convention, if less than 70% of the air can be exhaled during the first second of an exhalation, obstruction is present. And the combination of obstruction on spirometry with the appropriate symptoms and smoke or other irritant exposure is what gives you a diagnosis of COPD. So COPD is staged by the degree of airflow obstruction, which is the percent predicted of FEV1, or one of the measures of lung function. However, more importantly, COPD is graded based on symptoms. So the severity or the degree of breathlessness, the types of activities that can cause breathlessness, and the frequency of exacerbations that may even lead to hospitalization. So for example, some patients may be alarmed to hear that they have 40% lung function or they're stage 3 COPD. But often those numbers are not as meaningful as the symptoms, and those symptoms are very much modifiable with the treatments that we have available, and I'll discuss that at the end. So who gets COPD? This is a classic picture of COPD that comes from Frank Netter, who's a famous medical illustrator who created the anatomy textbook that many of us use in medical school. For a very long time, the picture of COPD was felt to be an older white man. Certainly that has changed over the last several decades, and much of that change is related to women taking up smoking and patterns of smoking changing during the 20th century. So here are some of the sobering statistics about COPD in women, and the reasons why we really need to be talking about this. There are 7 million women in the US who have COPD. Millions more have symptoms, but they're not diagnosed or treated. And women have higher rates of COPD than men, particularly at a younger age. COPD is the third leading cause of death in the United States. The number of deaths among women with COPD is more than quadrupled since 1980. You can see early on, men had twice the number of deaths from COPD than women. However, there's a sharp increase in women, and by the year 2000, women have overtaken men, and there are more deaths from COPD in women than in men. And rightly so, women tend to have a concern about cancer, particularly breast cancer, but it may surprise you to hear that women are more likely to die from COPD than from breast cancer and lung cancer combined. So let's take a step back and just look at the history of how women started to smoke in the 20th century. In the beginning, the early 1900s, smoking was frowned upon in women. It was considered a dirty habit. In 1911, an antitrust act broke up the American Tobacco Trust. This led to the creation of multiple companies that then engaged in competition, marketing, and branding. So for example, Marlboro was initially marketed towards women with the slogan, "Mild as May," and "Ivory tips protect the lips." And early on, the advertisements appealed to women's desire for weight control and beauty. In the 1920s, this ad from Lucky Cigarettes suggests that you reach for a Lucky instead of a sweet. Tobacco ads also targeted women's desire for equality with men. An event occurred in 1929. Edward Bernays, who's considered the father of public relations, who was at this time employed by the American Tobacco Trust, staged a display of suffragists smoking at a parade and described their cigarettes as their torches of freedom. So these ads were really looking at equality, autonomy, empowerment, and they included powerful and inspirational women such as Amelia Earhart. The tobacco companies, in fact, used registered nurses in lessons for women to teach them how to smoke cigarettes with the proper etiquette. By World War II, cigarette smoking was widely accepted in women. And the ads continued to appeal to women's desire for equality and empowerment with slogans such as "Believe in yourself" or "You're so smart to smoke." In 1968, Philip Morris came out with Virginia Slims, which were the first cigarettes that were specifically for women. Their slogan was, "You've come a long way, baby." And it did, at that time, target the burgeoning women's lib movement. And even though the Surgeon General came out with their landmark comments on the health effects of smoking in 1964, smoking in women continued to increase for several years afterwards, in part because of marketing such as this towards women. So in fact, in the 5 years after Virginia Slims were introduced, smoking in 12-year-old girls increased by 110%. Smoking in women did finally begin to decrease in the 1980s because of efforts including health warnings, smoking bans in the workplace and in public places, smoking bans finally in bars and restaurants as well. So this graph shows that women began smoking much later than men. So in blue is the graph of smoking rates in men, in red in women. And it also demonstrates that there's a lag in the development of COPD deaths, which is the dotted line. So in women who started smoking later, COPD deaths have risen quite dramatically and only now started to plateau. We've certainly made a lot of progress in the United States as far as reducing the prevalence of smoking, although there's absolutely more work to be done. But worldwide, this continues to be an increasing problem, and by 2025, it's estimated that 20% of smokers worldwide will be women. So the story doesn't end here. The reason that women get COPD is not simply because they began to smoke in the 20th century. There are some physiologic differences that make women more susceptible to developing COPD. Women are more susceptible to smaller amounts of cigarette smoke. And partly it's because their lungs are simply smaller. So in childhood, girls' lungs are more developed than boys. At puberty, the boys' thoracic cages grow more and they end up with 25% more lung function than women. So women's airways are smaller. They have less respiratory muscle to move air in and out. Lung irritants can get more concentrated and cause more damage. The sex hormones also have an effect. So we know that estrogen changes the metabolism of chemicals in cigarette smoke and makes female lungs more susceptible to oxidant stress and airway injury. Estrogen also upregulates a gene that leads to mucus production. And we know that mucus within the airway is part of the problem of airflow obstruction. Estrogen stimulates eosinophilic inflammation, a type of inflammation that tends to worsen asthma, and long-standing, poorly controlled asthma is a risk factor for COPD. Women also appear to be more susceptible to developing inflammation from lung irritants. So when CT scans are done on women smokers as early as their 20s, there are already some signs of bronchiolitis or inflammation in the small airways. Women are also more likely to have coexistent asthma and airway hyperresponsiveness, which means sort of a twitchiness or sensitivity in the airways. And those findings are associated with an accelerated loss of lung function. Women are more likely to have chronic bronchitis, while men are more likely to have emphysema. Women's airways are smaller, have smaller lumens because of thicker airway walls. So this combination of a greater sensitivity to inhaled irritants and more lung inflammation means that women are more likely to develop COPD with a lower smoke exposure, even less than 20 pack years. And they're more likely to develop COPD at a younger age, less than the age of 60. Unfortunately, women have a steeper decline in lung function and loss of lung density on CAT scan than men do, particularly after the age of 45. Women with COPD have 25% more exacerbations or flare-ups in their symptoms than men do. And women are 2 to 3 times more likely to be hospitalized for COPD as compared to men. Women also have different comorbid illnesses. They're more likely to have asthma, osteoporosis, anxiety, and depression. All of these need to be recognized and treated, and they may in fact affect our approach to the treatment of COPD. Women are less likely than men to have alcoholism and ischemic heart disease. So let's shift gears a little bit and just talk about COPD in non-smokers. About 10 to 20% of cases of COPD are related to causes other than cigarette smoke. And women are vulnerable to those causes. So women with COPD are 1.5 times more likely to have never smoked than men with COPD. A major cause worldwide is biomass fuels. So that includes wood, animal waste that may be burned in a domestic environment for heating or cooking. Worldwide, these types of fuels are used in half of households and 90% of rural households. Women culturally have more domestic responsibilities than men, so they may have a high exposure to these fuels, which are burned in an atmosphere with low ventilation. So in developing countries, half of deaths from COPD are attributable to biomass fuel, and of these deaths, 75% are in women. Women now work in industries with occupational exposures that can cause COPD. So this includes farming, unregulated cottage industries such as brick making, fish smoking, tobacco curing, and leather working. This picture demonstrates women who are smoking fish, and clearly the air quality is poor. Women are also now working in industries that were formerly dominated by men, like plastics, rubber and textile manufacturing, spray painting, and welding. Aside from the physiology, there are also sociologic factors that affect how women are diagnosed and treated for COPD. There's a male-dominated bias in medical providers historically in how we recognize COPD. So women are less likely than men to be diagnosed with COPD. There's a landmark study done about 15 years ago in which healthcare providers were presented with a hypothetical case, a patient with cough, shortness of breath, and wheeze, and a smoking history. When that hypothetical patient was described as male, the medical providers were more likely to give a diagnosis of COPD. When that hypothetical patient was a female, asthma was more likely. That bias did seem to diminish when those healthcare providers were given spirometry data. However, only 20% of the providers said that they would have ordered spirometry. So we know that women are less likely than men to get a spirometry test with the same smoking history. Women also experience symptoms differently than men. They experience more shortness of breath with the same severity of disease. There's much more depression, although only a fraction of women are adequately treated. There's a lower health-related quality of life. It's lower at an earlier age, and it's lower than men with the same severity of disease. Women may require more social support and interpersonal connection. Women are more likely than men to turn to online forums or to patient support groups. And unfortunately, women are also less likely to successfully quit smoking with nicotine replacement. However, women are more likely to be offered smoking cessation as compared to men. And when women do quit, they experience a much greater benefit than men. In fact, the improvement in lung function is 2.5 times the improvement in lung function that men would experience quitting smoking. Small studies have also suggested that women are less likely to use their inhalers correctly and also less likely to attend pulmonary rehab. So what about treatment? At this time, there's no evidence to suggest that a woman with COPD should receive any different treatment than a man with COPD. However, this is based on guidelines that come from clinical trials that enrolled many more men than women. This may change in time. The treatment regimen is generally based on the GOLD grade, so the severity of symptoms. So I would be remiss to not say that the primary treatment for COPD in somebody who's still smoking is smoking cessation. So this graph demonstrates lung function with age, and you can see in red is the lung function of somebody who's never smoked. There is a slight decline with age that occurs. In blue is the lung function of somebody who is smoking, and you can see that the decline in lung function is much more rapid. If that smoker quits smoking at the age of 45, the decrease in lung function will be attenuated and will return to the rate of decline simply related to age. And even quitting smoking at the age of 65, although it may be after the diagnosis of COPD is made and after symptoms develop, there is still benefit in longevity. So the medications, I'm not going to go through in detail. It can include rescue medications, short-acting medications that open up the airways, bronchodilators, and are generally used as needed, as well as maintenance medications, which include long-acting bronchodilators, maybe long-acting beta agonists and long-acting antimuscarinic agents, as well as inhaled corticosteroids. And these are generally used once or twice a day. PDE4 inhibitors are an oral bronchodilator that may be used in patients who have more severe COPD with chronic bronchitis. These medications have in general been around for a while. What's new is the combination of medications and the delivery devices, which have changed over time to be more efficacious. Antibiotics and oral steroids are generally reserved for exacerbations to be used in the short term if the symptoms are flaring up. There are also non-pharmacologic treatments. So first and foremost is pulmonary rehab, which is a formal exercise program to improve conditioning in patients who have respiratory illness. It's extremely effective. I refer all of my patients. It improves quality of life, exercise capacity, lung function. We know that respiratory infections can worsen, can cause an exacerbation, which results in worsening lung function. So vaccination against the flu and pneumonia are extremely important to prevent infections that may result in exacerbation. supplemental oxygen can have substantial benefit in those patients who need and qualify for it, who do have significant hypoxemia or low oxygen levels. And then we talked about how air trapping or excess size of the lungs is a main part of COPD. One way to mechanically address this is through lung volume reduction procedures, which can be either done surgically or bronchoscopically to remove a portion of the lung where air is trapped. And this can be done for very selected patients who may benefit from it. And then finally, lung transplant is really reserved for a small fraction of patients who are very selected as well. So how can we improve the treatment of COPD in women? Clearly, we need to prevent girls from starting to smoke. We need to do better with smoking cessation. We know that women don't respond as well to nicotine replacement products. So we need to potentially develop techniques, especially targeting the behavioral element that may be tailored to women. We need to worldwide protect women from inhaled irritants such as biomass fuels and occupational exposures. And this may include education regarding alternative fuels or improved ventilation. We need to screen and treat women for comorbid illnesses, such as depression and osteoporosis. We should raise awareness of COPD to improve the timely diagnosis and treatment. So part of this is adjusting that male-dominated bias in the medical provider view of COPD, increasing the use of spirometry for the diagnosis of COPD. We should do better with women's health advocacy and education of the community about COPD with programs such as this. And then individual awareness of symptoms. Education that symptoms of COPD can develop decades after smoking cessation. You may be slowing down not simply because of age and deconditioning and weight gain, but you may have COPD as the cause of slowing down if you've got a smoking history. And then community programs for social support, such as the Better Breathers Club or online forums. We know that women do respond well to programs such as these. And we need to improve research in COPD, clearly more funding, enroll more women in these clinical trials, and then look specifically at sex-specific treatment data, so we can be sure that women should be treated the same as men, given their different physiology. So these are my final take-home points. COPD is a chronic respiratory illness. It's caused by an inhaled irritant, usually cigarette smoke, that leads to airflow obstruction and symptoms including breathlessness, cough, phlegm, and wheeze. COPD is an epidemic in women for several reasons. The effects of widespread smoking in the 20th century, the physiologic susceptibility of women, and other environmental factors that affect women. COPD in women may be under-recognized by medical providers, and we need to improve awareness. And finally, the early recognition and appropriate treatment of COPD can improve symptoms and delay progression of the illness. So thank you all for listening. Here are my references, and we'll go ahead and address some questions. Okay, so one of the questions is, what's a good technique for smoking cessation? So there are a number of products that are available, nicotine replacement products, which include the patch, the gum, lozenge. Generally, a combination of nicotine replacement products is one of the most effective methods. So I generally recommend using a combination of the patch, which gives you a long-acting nicotine replacement over 24 hours, as well as using something short-acting like the gum or the lozenge as needed for any cravings. There are other non-nicotine replacement products available. So bupropion and Varenicline are two medications out there that help with the cravings. Bupropion is an antidepressant, which is effective, and then Varenicline, the brand name is Chantix, is also highly effective. And those I generally reserve for anybody who is not responding to the nicotine replacement. But clearly, addressing all of the behavioral aspects is very essential. So along these lines, we have the question of whether vaping is safe, whether that should be an alternative to cigarette smoking. So vaping or electronic cigarettes use heat to aerosolize a liquid that typically includes nicotine. These products are not regulated, so there's varying purity and content. We don't know what the long-term safety is for electronic cigarettes. What we do know is that the aerosol that is produced does include carcinogens, known carcinogens, such as formaldehyde and acetone. So they're certainly not good for you. Another sociologic concern is that because they contain sweeteners, flavors, they tend to appeal to children. And any children that get a hold of them could suffer nicotine toxicity. And teens that are using electronic cigarettes are much more likely to then go on and smoke cigarettes as well. And studies have demonstrated that the use of electronic cigarettes is actually not an effective way to assist in smoking cessation. All right. And how about is COPD genetic? COPD is probably genetic, related to a variety of genetic factors. There's really only one that's widely known and can be tested for, and that's alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin is a protein that protects the lung from being degraded by other proteins. And when the alpha-1 is deficient, the lung can be destroyed and lead to emphysema at an earlier age. And this is tested for with a blood test. We generally recommend that anybody who's diagnosed with COPD be tested for alpha-1 antitrypsin deficiency. It's quite rare, but if it is diagnosed, it's treated differently with a replacement of the alpha-1 antitrypsin protein to protect the lung from any further degradation. Okay, so I think we'll conclude here. I'd like to thank you all for tuning in and for your time today.